everyone. Welcome to Stories of Care, the podcast that covers infection prevention and control and health equity in the healthcare setting. Today, we are really excited to have Dr. James Lewis with us from Washington, who he heads up public health department there. Can you tell us a little bit about your career and how you've gotten there, Dr. Lewis?
Yeah, sure. Thanks. And good to see you, Megan. I started, with infectious disease back at the University of North Carolina, where we were together for a little while, worked together for a little while. And then from there, did preventive medicine and got my master's in public health and epidemiology, and eventually started working at the state health department in North Carolina, where I was the medical director for the Healthcare Associated Infection Prevention Program at the state level. So we did a lot of work with infection prevention in various healthcare settings, including a lot of long-term care work, as well as antimicrobial stewardship and multi-drug resistant organism outbreak response. And then due to family reasons, ended up relocating here to Washington, the Seattle area over the pandemic, and worked with healthcare facilities in responding to COVID at Public Health Seattle and King County until I became the health officer for Snohomish County here in Western Washington, which is just the county just north of King County.
Awesome. And it's great to see you after so long. I remember walking in first day of fellowship, and you were the cool, young, recently graduated fellow that could just be chill and be willing to answer all of the 5 million questions we had for you. So it's really good to see you travel from then to now. It's kind of a whole world different. But so now that you're out in Washington, you've been working a lot in the midst of the pandemic. You kind of relocated there during that time, right?
Yeah, that's right. Yeah, right at the very beginning. I was actually started the weekend before I started on Monday. They had identified that first outbreak at Life Care here in the Seattle area, and I went there to help respond to that first outbreak of COVID in March 2020.
Wow. And what about that whole situation made you decide to say, hey, I want to stick around and be a part of the public health department and continue to do this work?
Yeah, it was really reinforcing to me to just continue my career path in public health. I really felt useful. I felt like I was doing important work. I felt like I was making a difference. It was incredibly tiring, and I think and this is going to sound crazy coming from someone who's done residency and fellowship as a medical professional, which I'm sure you'll relate to. But I think it was the hardest I've worked. Those like initial at least 6 to 8 months were probably the hardest I've ever worked in my life. I mean, we were all working 80 or more hours a week, and constantly on email meetings, going out into the field. It was really intense. We had a large group of people from CDC, but in the end of the day, it really just felt like we were making a difference, and that was the reason why public health existed, was to respond to situations like this. And so yeah, to me, I totally understand how people got burnt out from that experience, but for me, it was really just reaffirming my desire to work in that area.
During those 6 to 8 months, when you were really in the community, in the hospital setting, doing everything, working with CDC, working really from we don't know what's going on, but we need to figure it out and try to stop it immediately. What were the biggest foci of your work? What type of settings were you really seeing this erupt in?
Yeah, so I mean, it was initially long-term care facilities. That was the major focus of our work. That was where the first outbreak happened. And as soon as we started looking, right after that, we started seeing outbreaks in multiple long-term care facilities. And so then the focus really became on making testing more available, and making sure we could understand and know who was infected, how it was getting transmitted. And then we, focused on getting all that information out to people. So there are, a large number of papers that came out of that work to kind of help prompt people on how to deal with this in their communities, because it was everywhere. Just because we found it first didn't mean it was only here in the Seattle area. And then soon thereafter, I was on phone calls with people in healthcare and public health across the country on a regular basis, trying to help people respond to outbreaks and in healthcare settings. And it was primarily long-term care for a while.
So tell us more about long-term care facilities. I know that's one of the topics we really wanted to hit on today, specifically LTACHs. First off, tell us what those are.
Yeah, so long-term care facilities is a broad term that's not really a technical term, and it can there are different types of long-term care facilities, and that can vary significantly from state to state on what types of facilities are licensed facilities in a given state. So here in Washington, we have three primary long-term care facilities, but there are a number of other kind of smaller or at least less numbered facilities as well. But the main ones that you think about when you think about people living in a nursing home are going to be skilled nursing facilities, which is what you would that's kind of your normal nursing home whenever you think about a nursing home. And then you have assisted living facilities, which is um, uh, places where folks might get some help with their care, but it's really an apartment building that just has some built-in extra supports. You might be able to get people to help cook your meals, give you your medications, maybe do some light kind of wound care and things like that. But they're really more almost like retirement communities, but with a little bit more support built into them that you can opt into. And then there's what we call adult family homes here in Washington, which are kind of in between a skilled nursing facility and assisted living facility, and they're usually in private homes and neighborhoods, and really focus on providing more of a home environment and home-based care. So those are the major ones. There are some other kind of facility types that are focused on providing care to people with developmental disabilities and other long-term health issues, but those are the ones we mainly think about. And then kind of separate to that, which is in between a hospital and a nursing home or a long-term care facility, is a long-term acute care hospital or a LTAC.
Mhm.
And that is what we were here today to talk mostly about. And those are, interesting places because they really feel much more like a nursing home in a lot of ways, or a skilled nursing facility in a lot of ways, but they provide a lot more advanced care, and they're technically licensed as hospitals, at least here in Washington, in my previous experience in North Carolina. And these folks in these facilities have a higher level of care needs. So they often have chronic indwelling devices. They often have, illnesses that lead them to be, highly immobile or require chronic ventilation, things like that. And so often have a lot of underlying medical problems, a lot of comorbidities, and often a lot of ongoing kind of acute medical issues like infections and things like that. So that's LTACs.
How long does somebody who enters an LTAC, what's the average length of stay that you see there?
That's a really good question. It can be extremely variable, but usually it's very long. So people who are in LTACs, I would say, are often in LTACs for several months. But that is a good question. I would have to verify that, but that has been my anecdotal experience. And sometimes even longer than that. Sometimes almost permanently, they kind of go back and forth between the LTAC and the hospital for the remainder of their life. And then if they do leave an LTAC, most people end up in other long-term care facilities. So stepping down to a skilled nursing facility, or even what we call a vent sniff, or a ventilator-capable skilled nursing facility. That's kind of a step in between a regular skilled nursing facility and an LTAC.
As you're talking, I mean, there's clearly this really important need for having LTACs, but you're also mentioning things that, as an ID physician, automatically trigger concern. Indwelling, long-term indwelling catheters or items of that nature. A lot of people together in a small space that have high complex needs. It just seems like the perfect storm for exposure to not just pathogens and infections, but even multi-drug resistant organisms. What are your thoughts on this as an ID doctor yourself?
Yeah, I mean, I think LTACs are very important, and I think the people who run them are doing the best they can, and really are doing
Mhm.
a good job with what they have available. Unfortunately, LTACs are suffering from the same issues that skilled nursing facilities and other long-term care facilities
Mhm.
have experienced even before the pandemic, but it was exacerbated during the pandemic even more, which is staffing shortages. So it's extremely common for these places to have really high turnover, and that leads to inconsistent infection prevention practices. That on top of folks having a lot of healthcare exposures, and most of them have a lot of antibiotic exposures, you have a real setup here for development of colonization or infection with multi-drug resistant organisms, as well as then transmission within the facility. So while CMS does require there be an infection preventionist on site at least part-time at long-term care facilities, including LTACHs. It's not required to be one full-time FT. And even if it were, with the turnover rate that happens where you're, having to train a new infection preventionist every several months for a lot of places, by the time they really get up and running on their infection prevention work, it's time to train a new person. So this really sets up places for, to not be as successful as they could be otherwise with stable staffing.
And then you're dealing with patients who have high acuity, already unfortunately understaffed, like so many parts of the healthcare world is right now, and have been for a long time, honestly.
Yeah.
And in that setting of what, 50 to 150 people who probably are already, as you mentioned, colonized because of their frequent exposure to healthcare at all different settings, and maybe even going back and forth between the acute care hospital and LTAC, it really seems not only are you behind, it's difficult because you're having to retrain somebody so frequently, but also just one infection preventionist for that many patients and that daunting of a challenge. That seems like a really, really large job and large shoes to fill.
Absolutely, it is. Yeah, and it's uh, yeah. I mean, I don't have anything else to add. That is a very big job. That's some very big shoes to fill, and a really tough spot to put somebody in. So what we're really seeing is that there is a role for public health to step in and provide infection prevention support.
What are some of the current challenges with that relationship, that communication, and kind of having that free flow?
Well, I do think that some of that improved during the pandemic because kind
Hmm.
of overall communication between healthcare organizations really improved between public health and healthcare organizations really improved during the pandemic because we were kind of all hands on deck and everybody needed support. So I'm really hoping we can maintain that and capitalize on it. And I think we're a little bit spoiled here in Western Washington. There's a really great collaborative atmosphere between all of our hospitals in Western Washington and a lot of our long-term care organizations and long-term care facilities. So I hope that that's experienced at places elsewhere, but I have a feeling we might be spoiled here and have a really good um, working relationship between a lot of our sectors of healthcare.
And with, as you mentioned, things improving even during the pandemic, were there possible solutions to helping fill this gap, helping to facilitate better communication that you saw pop up during the pandemic that you have been carrying through, or even things that you want to build upon to create potential solutions for the future?
Yeah, I think one big thing is we've continued to host regular check-ins with kind of healthcare partners and public health through various pathways or channels where we're regularly meeting with each other, regularly sending out, kind of update information or concerns. And so I think just the open lines of communication and those relationships that were formed where you can reach out to somebody now because you worked together during the pandemic, that is definitely, we're all working to maintain that. And we're going to continue to build on those and improve on those kind of check-ins to make them more useful for people rather than just another meeting that they have to attend or cancel. So I think that's a big pathway. The other thing is, we had a large meeting during the pandemic, excuse me, where a large number of long-term care facilities joined across the state to talk about infection prevention issues, particularly related to COVID. And we had people from regulatory, people from hospital side of things, people from long-term care, the professional organizations. They all joined this meeting, local public health, state public health, and we fielded questions from long-term care facilities. And there was people with authority there that could answer the questions with confidence, and then the facilities could be confident in the information they were getting. And so we're going to revive that here in Washington to on a less frequent basis. So we'll probably do it quarterly so that the long-term care facilities have access to these kind of channels of authority and get the information they need in a timely manner. So I think that will be a good approach. And then I think another way where I would love to see Washington do something similar to what in North Carolina, the North Carolina statewide program for infection control and epidemiology. So we're starting to talk about a program like that and maybe getting that up and running, which could be a whole nother
I
talk.
was just
But
like, tell me more about this program. I know I was in North Carolina with you, but you were doing so much more with the state public health than we were involved
yeah,
in. So I don't know as much about this program.
yeah, so one big thing, right, with infection prevention kind of baseline competency, you want to be able to ensure that in some way. And
Hmm.
so in North Carolina, they did a kind of a unique approach. I'm not aware of any other states that have this same approach, but they legislated that all healthcare facilities that perform any kind of medical procedure that
Hmm.
includes lab draws or immunizations should have a uh, trained infection preventionist on site, and that
Oh.
should be trained in a state by a state approved infection prevention course targeted at the type of facility they work in. So when that got started, they initiated the North Carolina statewide program for infection control and epidemiology to develop the training that would be approved by the state. And so that's the only, or at least when I left North Carolina in 2020, that was the only state approved training course was through this program. And so people, whenever they got appointed to an infection prevention job, they were supposed to take the training from the SPICE program. They paid for that training, and that's what funded that program. And then
Mm.
the program worked with the state and all the facilities that came and took that training to identify infection prevention related priorities for the state of North Carolina so they could update and retarget their trainings towards issues that were pertinent to North Carolina facilities, and that might be different from other states. And so what that does is it ensured a baseline level of education you receive around infection prevention. It's self-sustaining because people have to pay to take the courses. You make the courses applicable to your location and continually update them and make them more effective. And on top of all that, it develops once you took the courses, you were kind of in this community now of infection preventionists, and there's a listserv that they use so people can ask questions and ask for support from their colleagues in infection prevention. And
Well, it also sounds like a really great pathway, especially for people who might be in healthcare but not in the infection prevention world, to
yeah,
be able to enter that world and thus broaden our pool of infection preventionists because that is yet another area where we have far too few for what we need.
yeah.
So for those who are at an LTAC, what are some of the unique risks and infection hotspots and things that would really need to be focused on that this course might have covered?
So I think the unique aspects of LTACs is just the acuity of the patients and the number of long-term devices they have and other kind of high levels of care they need. So, a lot of folks are immobile. They have to be turned on a regular basis. They have chronic wounds. They have, indwelling catheters from, central lines for, bloodstream catheters to suprapubic catheters or chronic Foley catheters or, trachs having to be on chronic ventilators, like all of these tubes, G tubes, all these things that get inside the body that are pathways for pathogens into the body. And so I think, that is probably the main thing that needs to get targeted to LTACs is how to manage all of these things in a way that maintains infection prevention and prevention of spread of pathogens within that environment, which is very difficult.
So tell me a little bit more about your time in North Carolina. I know when you were there, you also worked with a KPC outbreak that happened, and there were some possible solutions that came out of that outbreak on how we could potentially prevent these things in the future. Tell us a little bit more about that.
We responded to several outbreaks, and I think most of them are in long-term care facilities. Occasionally we had one in hospitals, but one unique intervention that that CDC developed and we implemented several times is the enhanced barrier precautions approach. So, you have these outbreaks in long-term care facilities, but and they're healthcare facilities, but they're also people's homes. So that's what's kind of interesting about long-term care facilities is you have this kind of unusual intersection between people's house and people, and it still being a healthcare facility where healthcare workers are there all the time. and healthcare is being provided all the time. And so, obviously, you want to prevent spread of multi-drug resistant organisms like KPC in these environments. But at the same time, you want people to be able to live their lives and be comfortable in their own homes. And so being on contact precautions or contact isolation is not particularly conducive to you feeling comfortable in your own home and being able to live your life. And it means you can't leave your room at all, essentially, unless you have to for a specific medical procedure. And that means you can't go, enjoy dinner with your colleagues or your peers. You can't, go take advantage of entertainment that might be provided at that facility or just socialization. And so it can be extremely isolating, as we're all very aware from what, went down during the pandemic. So what enhanced barrier precautions does is it's kind of a compromise approach where this person is colonized with a organism that you don't want to spread further, like KPC, but you get them to a point where the risk of transmission is much lower. So if they're not having active diarrhea, they're not having active uncontained drainage from wounds, they're not having active vomiting, things like that can't be readily contained, then they can get out and go about their business in the facility because the potentially infectious parts of their body are contained now and covered and pose much less of a risk for transmission within the facility. And so that's one approach that we used to both help contain outbreaks, but also allow people to, have compassion for people and allow them to get back to their lives. So,
Well, that's another great intervention. I was even thinking about the one where you created a specific form to help really with the communication between the different healthcare settings
oh,
that these
right.
people
Yes.
travel between.
So yeah, we had a really great experience with we had a large outbreak that was actually among a couple different long-term care facilities and a hospital. And it definitely seemed like the communication between these facilities was a big part of the problem. So we developed, based on some CDC forms that had already been created, an interfacility transfer form product that you would create in triplicate, right? So the facility gets one, that's the transferring facility where the person's coming from. And then you give one copy to the EMS or whatever the transferring agency is, the person that's actually physically taking the patient from one place to another gets one. And then the third one goes to the accepting facility. So the hospital or long-term care facility, depending on which way you're going. And what was on this form was a lot of relevant health information and medical history, but also their colonization or infection status with multi-drug resistant organisms. And so that was right there on the form. They didn't have to guess. They knew this person should be in isolation or contact precautions. And they could do that without having to rely on trying to get in touch with another facility, because as you said, people have different shifts, you have different people get busy, they're working, they're rounding, they're caring for patients, and so getting in touch with somebody can take hours if not days. And also getting through all the medical records can be very challenging as well, even if you do get them all, and if you get them all when the person shows up, which is not always the case. So yeah, and we had really good success with that. Obviously, it's another form to fill out, and so we had some initial concern about that, and like, are people actually going to do it? But we did a concentrated effort to implement this in this one geographic area, and we found significant improvement in the risk of transmission and the affected facilities during that outbreak. And then ongoing afterwards, we had fewer outbreaks moving forward once that was um, implemented, and people really bought into it, and it was very successful. So I think it just goes to show this can be a really effective mode of communication and prevention of spread of these organisms, but you really have to have buy-in from everybody across the healthcare sector, because if just one part of the continuum adheres to it but not the rest, then it ends up creating tension, and also it's just not successful.
That's a really great example. But there was one other thing that you had brought up before too, about creating a registry for MDROs. Have you been doing this in Washington? Is this something that you're pursuing?
So it is something that kind of a lot of public health agencies are interested in, and something that CDC is interested in. And there's a bunch of different ways to approach that. You could use your surveillance system to flag people and put them in a registry that then you track. We are doing it in a way here in Washington that I think is really interesting, and it's through a partner. Uh, um, Called Collective Medical Technologies is the place that Washington Department of Health is contracted with. And what it does is it is a company that gets healthcare admission data from a lot of different sectors and across the healthcare continuum, including long-term care and acute care. And what it can do is it can flag individuals who get admitted to different healthcare facilities based on something you're interested in. So, for instance, with our Candida auris outbreak, if you can flag people who have tested positive for Candida auris, so that if you get transferred to a new facility, public health gets notified in that jurisdiction where that facility is, and then public health can tell that receiving facility, hey, you got this person who has Candida auris, did you know this? And then they can put them on precautions. Hopefully they already are, but if not, then you do it much more quickly than you could before. The other thing, you can also flag people who are coming from an outbreak facility who you don't know are positive yet, right? So if we have a facility who has an outbreak of Candida auris, and we have this period of time where we're concerned transmission was occurring, and then so someone was there during that time frame and they get transferred to another hospital, and we would recommend that person get screened, we can then notify the facility that received them, hey, put them on preemptive contact precautions and get them screened. Public health can help you with that. And then we're working on a way to where the hospitals can actually sign up for the service themselves through the Department of Health, so that they just get directly notified and takes public health out of needing to be that middle person in that process.
Honestly, from everything that you're talking about, all of these different solutions, things you've used in the past, pre-pandemic, and then also after the height of the pandemic as we've been coming down, it seems like really public health departments are playing a huge role now, even more so than I realized, in helping to facilitate a lot of this communication, helping to make IP a little bit more robust in even these long-term settings. Well, it's been really great having you on, Dr. Lewis, and seeing you again after so many years. If
Yeah.
there is anything that you want to leave our audience with today, what is the final message?
I think it's just that, communication and relationships are so important. And so, developing that relationship with, if you're a hospital, developing that relationship with your local health department and, your kind of surrounding long-term care facilities, the ones that refer patients to you the most, or that you refer patients back out to the most, and developing those relationships with the leaders of those facilities and the leaders of public health is really important, because then when you need something, that relationship already exists, and people are it's just much easier to help one another once you already have that pre-existing relationship. So that's what I would say. And then just also for everyone to know that infection prevention is a tough profession, mostly because we don't have enough people doing it, and we really need to advocate for building that infrastructure in your facilities. So if you get an opportunity to talk to your infection prevention team, either at your long-term care facility or your hospital, or at public health, do advocacy for getting them the resources that they need, because it's almost certain that your infection prevention team is chronically under-resourced and underfunded at your facility, as that's a common issue nationwide. So please support your infection prevention teams.
Awesome. Well, no, it's been great having you on. It's been great seeing you again. And I just really appreciate you taking the time and teaching us more about LTACHs and how public health can really be the way to help facilitate that communication for better care in the future.
Yeah, thanks for having me. It's been great talking to you.
Stories of Care is a publication of the AMA and CDC's Project Firstline. Project Firstline is a national infection control training collaborative working to provide all healthcare professionals with the foundational infection control knowledge they need and deserve to protect themselves, their patients, their coworkers, and their communities. For more information, trainings, and other infection control resources, visit cdc.gov/projectfirstline and amafirstline.org.